welcome to the deep dive. If you've ever pictured an emergency department, you probably imagine, well, intense activity, right?
Oh, absolutely. It's often described as controlled chaos.
Exactly. Alarms going off, teams moving fast, making these lightning decisions, lives literally hanging in the balance. It's, high stakes.
Definitely.
So the big question we're tackling today is, how do these medical teams actually bring order to all that, especially when a patient's survival depends on every single move they make? For this deep dive, we're going to unpack the really systematic way they manage trauma patients. From the moment they arrive, maybe in chaos, right through to getting the care they need. We're using insights from systematic trauma management and patient prioritization in the ED. Think of this as a shortcut to understanding that crucial life-saving process.
That's a great way to put it. And it really is more than just following steps. It's a whole mindset, a method. Evaluating and treating things almost simultaneously. The idea is to give you a clear picture of the principles and the key actions that make a difference. It's vital stuff.
Okay, let's jump in. The ED is obviously the front line for serious injuries, and our source really hammers home that having a systematic approach is, well, essential. This often follows frameworks like ATLS Advanced Trauma Life Support. It's a global standard, right?
It is. ATLS provides that step-by-step structure. The core idea really is treat problems as they are found.
Even before you know exactly what's wrong.
Yeah, precisely, because you don't have time to wait for a full diagnosis when someone's life is immediately threatened. It's about addressing the biggest threats first. And this whole systematic process is built around an acronym, CABCDE. That's the backbone of immediate trauma care.
CABCDE. Okay, let's break that down. Starting with a primary survey, that super quick initial assessment. The goal here is finding and fixing the immediate life threats. Yeah.
Exactly. And the C comes first for a reason. Catastrophic hemorrhage control.
Makes sense. Stop the massive bleeding first.
Right. If you see major external bleeding, the very first thing is direct pressure. Simple, but incredibly effective, buys critical time.
And the source mentions a specific drug here too, tranexamic acid or TXA. What's the deal with that?
Yes, TXA. It's given pretty quickly, often within 3 hours, to trauma patients who are bleeding significantly or who you suspect might be. It basically helps the body's own clotting system work better. It doesn't stop the bleeding itself, but it prevents clots from breaking down too quickly. It's a key intervention.
Got it. So control the catastrophic bleed, then what?
Then we move to A, airway maintenance, but always with C-spine control. You have to protect the neck. So the airway check is fast. Is it open? Can air get through? Any obvious blood, vomit, debris, any facial injury suggesting a problem.
And the C-spine part, protecting the neck, you mentioned that's critical in blunt trauma. The rule is basically assume it's broken until proven otherwise.
Pretty much, yeah. Assume an unstable cervical spine injury until it's formally cleared. So you keep the neck stabilized, often manually at first. That's MILS, manual inline stabilization.
Okay. And the source mentions C-collars are maybe a bit controversial now.
Yeah, there's some debate. Hard collars can have downsides. So sometimes, if the spine isn't cleared, they might use head blocks or even rolled blankets taped to the trolley alongside the MILS. The key is minimizing movement.
Right. And if the airway is blocked or the patient's condition is worsening fast,
then intubation is often necessary. That's usually done via rapid sequence intubation or RSI. It's a very structured, quick procedure using specific drugs to secure the airway safely. And confirming the tube is in the right place is absolutely vital. You can't guess. Ideally, you use continuous waveform capnography that shows CO2 levels breath by breath.
And you mentioned a jaw thrust.
Yes. If you just need to open the airway quickly without intubating yet, a jaw thrust maneuver is preferred over a head tilt chin lift because it moves the C-spine less.
Okay, airway secured.
Yeah.
Next is B, breathing and ventilation, making sure they can actually breathe properly. How's that check so fast?
You expose the chest fully. Look at the respiratory rate, how much effort they're making. Listen to both sides for air entry. Feel the chest wall for crepitus, that crackling feeling, or flail segments where ribs are broken in multiple places. It's very hands-on.
And this is where some really scary things can be found, right? Immediate life threats in the chest.
Exactly. This is critical. You might find a tension pneumothorax, that's trapped air collapsing a lung and squashing the heart. You'd hear hyperresonance when tapping the chest, maybe absent breath sounds. That needs immediate needle decompression, sticking a needle in to let the air out, followed by a chest tube.
Wow. Okay. What else?
Massive hemothorax. Lots of blood filling the chest cavity. You'd suspect this with dullness to percussion and signs of shock. Needs an emergency chest drain right away. Sometimes they can even salvage and return that blood.
Cell salvage, right.
Then there's an open sucking chest wound, literally a hole in the chest wall sucking air. You cover it with a special 3-sided dressing to let air out but not in.
In a flail chest.
That's where a section of ribs is broken and moves paradoxically in when the patient breathes in, out when they breathe out. Very painful, compromises breathing, needs good pain relief, sometimes intubation.
And always high-flow oxygen, I assume.
Always. High-flow O2 is standard, aiming for specific oxygen saturation levels, usually 94 or 98%, maybe slightly lower for some COPD patients. But the goal is oxygen delivery.
Makes sense. So after B is C, circulation and hemorrhage control. Assessing for shock.
Yeah, looking for signs of shock, level of consciousness, pulse rate and quality, blood pressure, skin color and temperature, how much urine they're making. Key red flags are systolic blood pressure under 90 and heart rate over 100. That screens shock.
And getting access is key here, right? 4B lines.
Absolutely critical. 2 large bore 5E lines, usually in the crooks of the elbows or forearms. If you can't get IV access quickly, especially in shock, then intraosseous IO access is the next step.
Drilling into the bone.
Yep. Sounds dramatic, but it's fast and provides reliable access straight into the vascular system. A lifesaver when IVs are tough.
Okay, access sorted. What about fluids? Just pump them full of saline.
Actually, the thinking on that has shifted quite a bit, especially with major bleeding. You want to minimize large volumes of crystalloids like saline or Ringer's lactate. Instead, the focus is on early, balanced resuscitation with blood products, red cells, plasma, and platelets, often in a 1.1.1 ratio. This helps prevent coagulopathy problems with blood clotting, which is a huge issue in trauma.
So blood products early. What if you don't know their blood type?
In profound shock, O-negative blood, the universal donor, can be given immediately while cross-matching is underway.
And you mentioned something called permissive hypotension, letting the blood pressure stay a bit low. That sounds risky.
It does, but it can be strategic. In patients with ongoing internal bleeding but no head injury, allowing the systolic pressure to sit around 90-100 mmHg might be better than pushing it higher with aggressive fluids.
Why is that?
The idea is to avoid popping the clot, dislodging early clots that are forming before surgeons can physically stop the bleeding source. It's a temporary measure, used carefully.
Okay, that's a tricky balance. What about specific bleeding sites, like the pelvis?
Pelvic fractures can bleed massively. If you suspect one based on the mechanism or initial feel, applying a pelvic binder or sling early is really important to stabilize the fracture and reduce the potential space for bleeding.
And the heart. Cardiac tamponade.
Yes, another critical C problem. Blood filling the sac around the heart, squeezing it, often seen with penetrating chest wounds. Classic signs are low BP, muffled heart sounds, raised neck veins, Beck's triad, but the neck veins might be flat if they're also hypovolemic.
How do you spot that quickly?
Ultrasound. The EFAST exam is key here. If it looks like tamponade and the patient is crashing, they might even need an emergency thoracotomy opening the chest right there in the ED.
Let's talk more about EFAST. Focused assessment with sonography and trauma. What does that actually involve?
It's a quick ultrasound scan, takes just a couple of minutes, done right at the bedside. It's non-invasive, repeatable. It looks for free fluid, usually blood in specific spots in the abdomen, around the heart, and in the chest cavity. Also looks for pneumothorax.
So it's mainly looking for internal bleeding or collapsed lungs.
Pretty much. It's super useful in shocked patients or those with penetrating torso trauma. A positive scan showing fluid in the abdomen strongly suggests intra-abdominal bleeding.
But it's not foolproof.
No, definitely not. A negative EFAST doesn't rule out significant injury, especially to solid organs or the bowel. It's a screening tool. It shouldn't delay other necessary imaging like CT scans if they're indicated, and the patient is stable enough.
Got it. Okay, so C, A, B, C. Next is D, disability, neurologic status.
Right. A quick neurocheck. We use the Glasgow Coma Scale, or GCS, to assess level of consciousness. Check pupil size and how they react to light. Look for any lateralizing signs weakness on one side, for example.
And simple things first, right? Like
Yeah.
blood sugar.
Absolutely crucial. Always check a fingerstick glucose if the GCS is low. Hypoglycemia can mimic head injury, and it's easily treatable with IV dextrose. And a really key point our source makes: never, ever assume a low GCS is just alcohol or drugs, especially if there's any possibility of head injury. You have to assume it's an intracranial issue until proven otherwise.
That's a critical takeaway. Are there specific GCS scores that trigger a higher level of care?
Yes, criteria exist for immediate transfer to a major trauma center. Things like a GCS less than 14, systolic BP under 90, or very slow or fast respiratory rates are definite triggers.
All right, that brings us to the last letter, E, exposure and environment.
Two key parts here. First, exposure. You need to fully undress the patient, completely. You have to look everywhere, front, back, perineum, to find all injuries. Things get missed otherwise.
Makes sense. You need to see everything. And environment.
That's about temperature control. Trauma patients lose heat incredibly easily, and hypothermia is really bad news. It messes up clotting, contributes to acidosis. It's part of the lethal triad of death and trauma.
So keeping them warm is vital.
Absolutely. Warm blankets, fluid warmers, forced air warming devices, whatever it takes to prevent or treat hypothermia. It's a core part of resuscitation.
You mentioned resuscitation happens alongside the primary survey, so it's not strictly sequential.
Not at all. As you find problems in the CA-BCDE survey, you treat them immediately. That is the initial resuscitation. Plus, other resuscitation tasks happen concurrently or right after, like inserting an NG or OG tube to decompress the stomach, or a urinary catheter, checking first for signs of urethral injury.
And sometimes surgery happens even before the secondary survey.
Yes. If there's life-threatening hemorrhage that can't be controlled otherwise, the patient might go straight to the operating room for damage control surgery just to stop the bleeding. The full assessment comes later.
Okay, so let's assume the patient is stabilized enough after the primary survey and initial resuscitation. What happens next?
Then comes the secondary survey. This is the detailed head-to-toe examination to identify all other injuries that weren't immediate life threats. It's thorough. But, and this is crucial, if the patient's condition worsens at any point during the secondary survey, you stop immediately and go right back to the primary survey. Reassess CA-BCDE, always.
Constant vigilance. And during the secondary survey, you're also getting history.
Yes, gathering the AMPLE history. Allergies, medications, past medical history, last meal, and the events leading up to the injury. Get it from the patient if possible, or paramedics, family, anyone who knows.
Okay, and the physical exam itself in the secondary survey, how detailed is it?
Very detailed. You examine the head and face again, looking for subtle skull fractures, signs of base of skull fracture like bruising behind the ear or around the eyes, fluid from the nose or ears. Palpate the facial bones, check the neck again for tenderness, swelling, tracheal position. Listen to the chest again, feel every rib. Examine the abdomen thoroughly, look, listen, feel. But remember, the abdominal exam can be unreliable, especially in altered or intoxicated patients. Imaging is often needed.
Right. What about the pelvis and extremities?
Assess pelvic stability gently. Check the perineum for bruising or blood. Examine all four limbs, look for deformity. Check range of motion if possible. And crucially, assess neurovascular status. Pulses, sensation, movement distally.
And the back. How do you check that safely?
With a careful log roll, maintaining spinal immobilization, you need at least 3 or 4 people. Inspect the entire back and palpate the thoracic and lumbar spine for tenderness or deformity.
Okay, quite comprehensive. Now, what about lab tests and imaging during or after all this?
Core labs are drawn early, often during resuscitation. Group and cross-match for blood, full blood count, urea and electrolytes, coagulation profile, and a venous blood gas, which gives quick info on lactate, glucose, acid-base status.
And imaging. CT scans seem central now.
They really are. CT is the standard for evaluating head, neck, chest, abdomen, and pelvis in major trauma. Often, they'll do a pan scan covering multiple regions. It's vital for head injuries. But again, the patient has to be stable enough to go to the scanner. Unstable patients get managed in the resuscitation bay, maybe with bedside ultrasound like EFAST, or they go straight to surgery.
Do x-rays still have a role?
Yes, they do. Portable x-rays of the chest and pelvis are often done early in resuscitation. Specific limb x-rays are obviously needed for suspected fractures, urinalysis to check for blood, and continuous ECG monitoring is standard.
It really sounds like a massive team effort.
Oh, absolutely. The source calls it a team sport, and that's spot on, especially in trauma. There are usually clear criteria for activating the full trauma team based on mechanism of injury, physiological signs, specific injury patterns.
And that team includes
ED doctors and nurses, trauma surgeons, anesthetists, radiologists or radiographers, respiratory therapists, pharmacists, social workers, support staff, all working together, coordinated by a designated team leader. The goal is often to get through that primary and secondary survey within about 30 minutes. And early consultation with the relevant surgical specialties is key.
Okay, theory is one thing. Let's make this real. Can we walk through a case, say a 35-year-old man, high-speed car crash into a tree, wasn't wearing a seatbelt? Paramedics say his GCS was 10 at the scene and his blood pressure was low.
Okay, perfect example. So based on that pre-hospital info, high speed, unrestrained, GCS under 14, hypotensive, that's an immediate major trauma team activation before he even arrives.
He gets wheeled into the resus bay. What happens first?
Team's ready. Primary survey, CABCDE, starts immediately simultaneously with treatment. C, catastrophic hemorrhage. Let's say he has a scalp laceration bleeding heavily, direct pressure applied. Given the mechanism and hypotension, they'd give TXA right away, suspecting internal bleeding too.
Okay. Airway and C-spine.
He's making gurgling sounds, obstructed airway, quick suction, maybe an oral airway initially. C-spine is manually stabilized immediately. His GCS on arrival is now 8. That warrants intubation. RSI is performed. Tube placement confirmed with capnography.
B, breathing.
Chest exposed. Let's say breath sounds are absent on the left, trachea feels shifted to the right, left chest sounds hyperresonant when tapped, classic tension pneumothorax.
Immediate action.
Immediate needle decompression in the chest wall, followed quickly by a formal chest-drain insertion. He's put on a ventilator with high-flow oxygen.
Recirculation.
BP is maybe 70-40, heart rate 130. He's pale, cool, definite shock. 2 large-bore IVs are running wide open. Fluid started, but massive hemorrhage protocol is activated, calling for blood, plasma, platelets, maybe ONEG blood initially. Given the high-energy mechanism, they slap on a pelvic binder prophylactically. An EFAST scan is done right there. Let's say it shows free fluid in the abdomen, around the spleen, and in the pelvis. No fluid around the heart.
So likely intra-abdominal bleeding confirmed. Okay, D, disability.
GCS remains 8 after intubation, so scored as E1, VT for intubated M5. Pupils checked, maybe equal and reactive for now. Blood glucose is normal. Document the baseline.
And E, exposure environment.
Cut off all clothes, maybe find some bruising on his back, flank area, cover him immediately with warm blankets, start active warming.
Wow. All happening super fast. What about the ongoing resuscitation?
While stabilizing, they'd insert a urinary catheter after checking the urethral opening for blood and an orogastric tube since he's intubated. The positive EFAST and ongoing instability mean an immediate call to the trauma surgeons.
Okay, let's say he stabilizes enough after initial interventions. Secondary survey time.
Right, head to toe now. AMPLA history from EMS. Examination reveals, say, a palpable depressed skull fracture, developing raccoon eyes, neck tenderness at C5, C6, multiple left rib fractures. Abdomen is distended and guarded, pelvis feels okay with the binder on, and crucially, his left thigh looks deformed, foot is cool, no pedal pulse, clear limb-threatening vascular injury. Right leg seems okay, back has bruising over the lumbar spine.
So, multiple major injuries identified. Investigations.
Blood show falling hemoglobin, high lactate, clotting issues, cross matches pending. Urgent CT head because of the GCS and suspected fracture. Then, once stable enough, a full CT pan scan head, C-spine, chest, abdomen, pelvis. Probably CT angiography of that injured leg too.
And the team coordinating all this.
Trauma team leader is directing. Neurosurgery consulted urgently for the head injury. General surgery for the abdominal bleed, he's likely heading to the OR soon. Orthopedics for the pelvis and that critical femur injury. Then admission to ICU for intensive monitoring and ongoing care. Clear handover is vital.
That case really illustrates the process in action. Incredible coordination.
It has to be.
So we focus on the major trauma patient, but the ED sees everything. How does this structured approach fit into the broader picture of just prioritizing everyone who walks in? Triage.
Right. Triage is the first sort, usually done by an experienced nurse. It's a quick assessment to identify how urgent the patient's needs are. Not a diagnosis, just an acuity level. Even at triage, simple interventions might happen. Ice, elevation, maybe ordering an x-ray to get the ball rolling.
And it's not fixed, right? Someone triaged as less urgent can become critical.
Absolutely. The source calls it the dynamic nature of assessment. Someone waiting with an ankle sprain who suddenly develops chest pain immediately gets bumped to the highest priority. The team has to be flexible.
Are there specific tools they use for general triage?
Yes, standardized scales are common. Things like the Canadian Triage and Acuity Scale, CTS, or the National Early Warning Score, new WS2, help categorize patients objectively based on vital signs and presenting complaints. There are also specific tools for mental health presentations or suspected conditions like pulmonary embolism, like the Wells score.
And the trauma triage criteria we mentioned earlier fit into this.
Exactly. Those physiological criteria, GCS, BP, respiratory rate, and specific injury patterns or patient factors Age, anticoagulants, pregnancy, trigger activation of the trauma system, bypassing some of the standard triage flow to get immediate specialist care.
It sounds efficient, but are there challenges?
Of course. Waiting times for lower acuity patients are a perennial issue. And the source points out that sometimes less demanding patients, like some elderly individuals, might wait longer or be under-triaged initially.
That's concerning, especially with elderly trauma.
Yes, there's a known issue of under-assessment in older trauma patients. They might not meet standard trauma team activation criteria, even with serious injuries. Initiatives like the Silver Safety Net aim to address this.
And the environment itself.
Overcrowding is a huge challenge in many EDs. It impacts patient flow, privacy, dignity. It puts pressure on the whole system. Ultimately, triage is about resource allocation matching the patient's needs to the available staff, beds, equipment, especially critical resources like ICU beds. That involves clinical judgment, severity assessment, prognosis, and ethical considerations. It loops back to that multidisciplinary team approach.
It's an incredibly complex system. We've gone from the chaos of arrival through this highly structured, systematic approach. It really shows the power of having that method, that teamwork.
It really does. That structure is what allows the team to function effectively under immense pressure, ensuring those critical life-saving steps aren't missed. It's about applying knowledge effectively when seconds count.
A fantastic deep dive into a critical process. So for our listeners, thinking about that speed, that precision, the resource constraints, what else could be considered when trying to optimize care in these high-pressure environments? Something to think about.